Can I call the next person, Dr. A.S. Majumder from Bangladesh, for his presentation on Beyond Drug Therapy. Dr. Majumder.
Good evening, ladies and gentlemen. First of all, I must thank Professor Naveen Nanda, Dr. Parashar, Dr. H.K. Chopra, Dr. Rakesh for organizing such a splendid job and inviting me to participate in this conference. For the next few minutes, I will be talking about the treatment of the hypertension beyond the drug therapy. First of all, I start with the case which we have to deal a few weeks back in my institute. This is a 52-year-old man who was a past smoker, hypertensive, diabetic, hypothyroid with obstructive sleep apnea and single vessel coronary artery disease. He was presented with headache and sleep disturbance for the last 3 weeks. His blood pressure was found to be 180 by 100. The medication was adjusted to losartan, 100 mg plus hydrochlorothiazide, atenolol 100 mg, amlodipine 5 mg. After 3 weeks, he has to add some more drugs. The prazosin 3 mg was added and the amlodipine was increased from 5 mg to 10 mg, and later spironolactone was also added. So finally the patient was receiving losartan, hydrochlorothiazide, atenolol, amlodipine, prazosin, spironolactone, but the BP was still not achieved the goal. So what we are dealing with? We are dealing with a case of difficult to control, or better to say resistant hypertension. And this is not an uncommon problem, if not common, it is not uncommon problem in day-to-day clinical practice by a cardiologist. In clinical practice, only 50% of the patients achieve adequate control of the BP to the guideline targets. This is the practical data. And 10 to 30% of the general hypertensives have resistant hypertension. And as you know, it is defined as the hypertension which is not controlled to the goal by the 3 drugs, at least one of which is diuretic, and the drugs are raised to the optimum doses. And this is data from the United States which showed that only 27% of the known hypertensive patients are controlled by the oral medications. And it is to show that as you increase the number of the drugs, we have to increase the number of the drugs to control the level of the blood pressure. So what to do? We have to possibility of the secondary hypertension should be considered and dealt with, and there is a scope of the newer modalities of the treatment. But it is important to distinguish between the apparent or the pseudo and true resistant hypertension. And the basic pathophysiology of the true resistant hypertension is the inappropriately high sympathetic outflow. And this is the clue for the development of the new modalities. So management steps in the resistant hypertension, we have to confirm that it is the true resistant hypertension. We identify the contributing factors, document the target organ damage, screen for the secondary causes of hypertension, start the conventional treatment up to the optimized doses, and then the new therapies, the device therapies. One is the renal denervation therapy, another is the carotid Baroreflex activation therapy. And this is not a very new concept. Actually, it is an old concept where there is a sympathectomy, surgical sympathectomy was done, and it was found that the blood pressure was lowered. And in that case, which we dealt with a few weeks back, we also thought of renal denervation therapy, and renal arteries were found to be suitable for renal denervation therapy, and his blood pressure was also high, 155 by 95 in the morning of the intervention. Catheter was positioned in the right renal and the left renal artery, and there is no complication during the procedure, and post-procedural blood pressure was the following 130/80 at the end of the 1 month, and we have to downgrade the amount of the antihypertensive drug. So renal denervation involves a catheter-based approach using a radio frequency energy to selectively disrupt the renal nerves. In a recent randomized trial, renal denervation resulted in a substantial decrease of the office blood pressure, and current evidence indicates that the technique has a favorable safety profile. We have to skip this one. You know that both the renal efferent arteries and the renal afferent arteries are involved in the pathogenesis and maintenance and sustenance of the high blood pressure. The first femoral artery catheterization is done with the tip of the catheter placed in the distal renal artery, and radio frequency energy is then applied to the vascular wall. Catheter is drawn back 1 to 2 centimeter and circumferentially rotated, and further radio frequency energy is applied and repeated 4 to 6 times in individual artery, and the contralateral renal artery is dealt with in the similar manner in the same setting. There is a animation of the procedure produced by the company which is developed this catheter, which is nowadays available in different countries. Just this is the usual other traditional renal artery, with the only speciality that we can rotate it circumferentially within the renal artery. And there is some studies. There is a Simplicity Hypertension 1 trial, Simplicity Hypertension 2 trial, and all these trials, they found that the effects are very effective. The renal denervation effects are very effective, and the procedures are reasonably safe. There is no serious adverse events, and there is only some minor adverse events as femoral artery pseudoaneurysm, post-procedural drop in blood pressure, so and so, but which is negligible. And the Simplicity Hypertension 3 clinical trial is ongoing trial, whose estimated primary completion time is March 2013, and with this study we can get the data which may influence the writing of the next guideline for the management of the systemic blood pressure. And it is though not yet approved by the FDA for commercial distribution in the US. This system is commercially available in Australia and Europe since April 2010. And these are I have already talked about. There is the German Renal Denervation Registry, which is established to enable the systemic follow-up of the patients treated with the renal denervations. Another device therapy is the carotid baroreflex activation therapy. The stimulating electrodes are implanted in the perivascular space around the carotid sinuses to reduce the sympathetic outflow from the cardiovascular control centers in the brain. The blood pressure responses was favorable in the uncontrolled studies, but less convincing in a randomized control trial. There is a currently concern about the overall safety of the technique, and this is the site where the baroreceptors are located, and baroreceptors are one of the important part of the control of the blood pressure, physiological blood pressure of the body, as we already know. But in the hypertensive patients, in the chronic hypertensive patients, the baroreceptors are reset at the higher level. So the concept is, if we stimulate these baroreceptors at a high energy, then there will be more stimuli will be generated, which will go to the central nervous system to inhibit the cardiac centers, thereby reducing the blood pressure. And this is the way how the baroreceptors act and how we can modulate the system. And this is the RIO system. This is the only one system is now available. The first generation RIO system and now the second generation RIO system or Barostim new is available. Implantation procedure is both carotid sinuses are surgically exposed and electrodes are placed around the carotid adventitial bilaterally. The leads are subcutaneously tunneled and connected to an implantable stimulation device placed in the subcutaneous position on the anterior chest wall like the permanent pacemaker generator implantation. And electrical baroreflex activation is then initiated on both the carotid sinuses simultaneously with incremental voltage increases until the chronic stimulation level is achieved. This is one CD is developed by the Rios company. I may skip it. There is trial, Baroreflex activation system study. There is a fast human proof of principle trial, device-based therapy of the hypertension trial, US feasibility trial. These are the trials which are going on. These are the trials. The summary of the adverse events of the baroreceptor stimulation therapy. There is some procedural complications, surgical complications, there may be nerve injury, the transient nerve injury, respiratory complications, wound complications, there may be hypertensive crisis or hypotensive crisis and device related stroke. Baroreflex activation therapy provides durable benefit in patients with resistant hypertension. This is a result of the long-term follow-up in the Rio's pivotal trial. This is published just a few months before in Journal of American Society of Hypertension. And this is the new generation Baroreflex activation system. The future questions will be, would the blood pressure lowering effects of these two types of the device therapy can be additive by the renal denervation therapy as well as the Baroreflex activation system. Ladies and gentlemen, in conclusion, we may say that the renal denervation and carotid Baroreflex activation therapy have brought about new hope for optimum control of the hypertension. Limited number of the trials and current evidence appears to be in favor of safety and efficacy. However, long-term efficacy and safety are still a concern, and there is a chances of the abuse remain. Sometimes the drugs will not be optimized rather than the new therapy will be taken place. High cost is a drawback. Indication, contraindication should be precisely defined. Standard guidelines should address the issue. Larger randomized trials are needed before routine applications. Till then, we have to be optimistic but not over-enthusiastic. Thank you for the patient hearing.
Thank you, Dr. Majumder, for a beautiful illustration of patients with resistant hypertension for Baroreflex activation device, BRAS, that is RIO system, and by renal denervation therapy, that is by the catheter stimulation of the renal nerves by the catheter procedure. So I think excellently he has illustrated the video by the video presentation. A decrease in blood pressure by those patients who are resistant to multiple drugs, despite giving a combination of beta blockers, diuretics, ACE inhibitors. With 4 drugs, no response, patient when is labeled resistant hypertension, these are the procedures beyond drug therapy can be opted for any patient coming with resistant hypertension. I thank you very much, Dr. Majumder, for your excellent presentation. Yeah. Yes. Please give a big hand for all the speakers. Yeah.
Hello, I am Professor Senani from Mumbai. Professor Majumder, nice lecture you gave. I have few points to make. One thing you said that 40 to 50% of hypertensives are resistant. I beg to differ.
10 to 30.
I beg to differ.
10 to 30% I said.
5 to 10% only. I always give a challenge that there is no blood pressure which I cannot control. I run a hypertension clinic. Number two, sir, you didn't mention anything about the salt intake, diet and lifestyle. Because the patient, if he's taking drugs and if he is taking salt, your drug will not work. You know, there are so many things in your combination of the drugs which you have shown, losartan and all that, that combination was poor, you know. So you have to look to the new molecules and see it. And I can tell you, next, let us correspond with each other. I'll give you my email. If you have got any, I'll be very, very happy to help you to control that patient. And tell me how many cases of sympatherectomy and this nerve denervation of the kidney you had seen it in your life. And how many cases? It was theoretical, no? No, but what I want to say, sir, in your practice, in your own practice, how many cases you have done it to control that pressure?
But not too many cases, but there are.
Tell me.
But there are
you
cases.
See, you are a scientist.
Yeah.
You can't say not too many cases. You say 2 cases or 20 cases. You have to mention because this is very rare. I have not done in any of my case, and I have controlled my patients.
But sometimes it happens that you can prescribe the drugs, but the patient compliance decreases as you increase the number and the dose of the drugs. And sometimes the drugs interfere with the
compliance
other.
decreases, then patient will be resistant, no? Yeah. Because patients, even in our India and in Bangladesh, still they come to us also. They are very poor compliant patients. So it is the patient's compliance. They are not following it. They don't take tablets. So you can't call that as resistant.
No, but we have to keep the options open. The door open for those patients coming with this. I mean, we should have the latest, what are the upcoming for patients to all the delegates, that their opinion is open about that, what are the options related to the last modality if the drug is not responding. Of course, the salt restriction and diet and everything is there.
Also, let me add, from mind-body medicine, I agree with the lifestyle issues you're bringing up there, Professor, that are crucial. And in addition, we are finding that hypnosis is being quite useful in lowering hypertension, particularly in difficult cases, and a combination of hypnosis and meditation, hypnotic meditation, also can be very good. But with the meditation, it's a little tricky. It tends to help a good bit at first, when people are first learning to get good at meditating. Then there is a middle period where people are starting to move a lot of energy, and I see actually blood pressure is going up during that time, not going down. And then finally the individual achieves a very high level of meditation, and they're able to lower blood pressure with that. In addition, these energy methods that are being mentioned here, there is such as what is called subtle energy, which is studied a lot in the United States. This is physical energy measured by an fMRI or a magneto-enhanced EEG. This is subtle energy. It's below Planck's constant as a level of mass, and it behaves very differently from energy at a higher level. This is micro energy versus macro, and it has been found to be extremely useful in lowering hypertension. So I wish to add these things in. These are newer methods that are now being validated scientifically. Thank you.
You will all agree that hypertension management is very important for the day-to-day practice by the practitioners, general practitioners, physicians, cardiologists, and to the also patients going for any surgical, non-cardiac surgical interventions. The first thing is that you have to manage and control blood pressure, hypertension. Then only the patient can be suitable taken for any surgical intervention, either by the surgeon or anybody else. So I think all the speakers have done a wonderful job, and they have clearly spoken about the role of drugs for the left ventricular regression and the role of early echocardiograph and also the patients with the resistant hypertension. If you have any questions, one question is allowed from the delegates. Can you have a thing, not able to audible? Can you give the... He wants to know about diastolic dysfunction, how you elaborate by the echocardiograph.
I think the issue was the diastolic dysfunction. If we can assess the diastolic functions of the left ventricle, then it can forecast the development of the left ventricular failure in the future. So I think the questioner was asking about this point.
Dr. Mahapatra, we are going running short of time.
We can use the card.
So I think we will have this discussion later on in the tea session. So I thank all the speakers, and first of all I want to thank the organizing committee, Dr. Chopra, Dr. Nanda, Dr. Rakesh Gupta and Dr. Parashar for giving me the opportunity for being the chairperson for this session. So I thank the speakers and I thank the delegates for the silent listening. Thank you very much.
Thank you very much, chairpersons. Ladies and gentlemen, that brings us to the end of the academic deliberations of day 1.